everyone, this is Savannah Smith, DNPS, and I'm going to be presenting on the topic of rheumatic fever and other consequences of streptococcal infections for my literature review. The objectives for my presentation are to understand the pathophysiology of rheumatic fever, identify the common presentation of a patient with rheumatic fever, identify differential diagnoses for rheumatic fever, understand common diagnostic tools used for rheumatic fever, identify the appropriate management plan for a patient with rheumatic fever, and to discuss patient education for rheumatic fever and review current research regarding rheumatic fever. Rheumatic fever is a systemic inflammatory disease that is caused by an immune and inflammatory response to infection by A beta hemolytic streptococci in genetically predisposed individuals. The acute form of rheumatic fever is a febrile illness which occurs approximately 2 to 3 weeks after infection. It is characterized by inflammation of the joints, skin, nervous system, and heart. Rheumatic fever, though not as prevalent in the United States, is still a major health hazard in most developing countries. It is the leading cause of cardiovascular death in the first 5 decades of life. If rheumatic fever is left untreated, it can cause scarring and deformities of the cardiac structures and result in rheumatic heart disease. Rheumatic fever occurs most often in children ages 5 to 8 years old, and if appropriate antibiotic therapy is given within the first 9 days of infection, rheumatic fever can be prevented. Once an individual has experienced one attack of acute rheumatic fever, they are more susceptible to recurrent attacks. During this presentation, I will discuss the pathophysiology, clinical presentation, potential differentials for complaint, red flags, immediate or non-urgent actions needed, important points of H&P, diagnostics and management/treatment goals, research discussing the progress of the disease, patient education, follow-up, and referral criteria for rheumatic fever. Now I'm going to discuss the pathophysiology. Acute rheumatic fever develops only after an infection by group A beta hemolytic streptococci. Streptococcal skin infections have a different progression than acute rheumatic fever because the strains of the microorganisms which infect the skin do not have the same antigenic molecules within their cell membranes that cause pharyngitis, and they therefore do not elicit the same kind of immune response. Acute rheumatic fever occurs as a result of an abnormal humoral and cell-mediated immune response to the M proteins on the microorganism that cross-react with normal tissues. Antibodies that are against streptococci bacterial antigens, which display a cross-sensitivity against lamellin. Lamellin is a protein that is present in extracellular tissues that surround the heart as well as the valves. Cardiac myosin and vitimin are other antigens that are targeted. Autoimmunity as well as intense inflammation cause diffuse, proliferative, and exudative lesions in connective tissues, especially the tissues of the heart, joints, and skin. With recurrent rheumatic fever attacks, it causes proliferative changes, which result in scarring, granulomas, and thrombosis. About 10% of individuals diagnosed with rheumatic fever develop rheumatic fever disease, which is a scarring and deformity of the cardiac structures. Other diseases that are associated with group A streptococcus include strep throat, scarlet fever, necrotizing fasciitis, and post-streptococcal glomerulonephritis. The common symptoms of acute rheumatic fever are fever, lymphadenopathy, urticaria, nausea, vomiting, and epistaxis, abdominal pain, and tachycardia. The major clinical manifestations of acute rheumatic fever are carditis, acute migratory polyarthritis, subcutaneous nodules, chorea, and erythema marginatum, which generally occurs in combination of 1 to 5 weeks following streptococcal infection of the pharynx. Acute rheumatic fever Cardiac manifestations may include previous undetected murmur caused by mitral valve or aortic valve dysfunction, chest pain, and pericardial rub caused by pericardial inflammation or unexplained cardiomegaly with heart failure. Acute migratory polyarthritis or inflammation of more than one joint may include all synovial joints, but the large joints of the extremities are most often affected. Generally, 2 or more joints are involved simultaneously or in succession. Each joint may be symptomatic for about 2 to 3 days, and overall polyarthritis may continue for up to 3 weeks. In less than 5% of cases, palpable subcutaneous nodules occur. They mature over bony prominences as well as along exterior tendons of elbows, wrists, knees, and ankles. Chorea is a disorder of the central nervous system that is characterized by sudden, aimless, irregular, involuntary movements. Chorea affects up to 15% of people with rheumatic fever. Erythema marginatum is an uncommon manifestation that presents as a distinctive truncal rash and accompanies rheumatic fever. It is an annular erythema with the appearance of non-pruritic pink erythematous macule, which spread outwards. Now we're going to discuss the history and physical. It's important to assess the history of recent exposure group A streptococcus because it assists in making a diagnosis. Key immediate diagnostic factors to consider when assessing a patient with suspected rheumatic fever are fever and joint pain. Fever occurs in nearly all cases at the onset of the illness. Joint pain is often extreme, and if the lower limbs are affected, the patient may be unable to walk. The joints that are most commonly affected are the knees, ankles, wrists, elbows, and hips. The pain is generally asymmetrical and does not always migrate and may be effective for hours up to a few days. Other common diagnostic factors include recent sore throat or scarlet fever, chest pain, shortness of breath, palpitations, heart murmur, pericardial rub, signs of cardiac failure, and swollen joints. Other diagnostic factors that are less common include restlessness, clumsiness, emotional lability, and personality changes, jerky and coordinated coriform movements, inability to maintain protrusion of the tongue, milkmaid's grip, spooning sign, pronator sign, erythema marginatum, subcutaneous nodules, in pregnancy or taking oral contraceptive pills. Approach to a patient with rheumatic fever. In patients that present with rheumatic fever, lymphadenopathy, arthalgia, nausea, vomiting, epistaxis, abdominal pain, tachycardia, the differential diagnoses to consider include, but are not limited to, rheumatoid arthritis, juvenile idiopathic arthritis, septic arthritis, systemic lupus, serum sickness, Lyme disease, infective endocarditis, viral myocarditis, Henoch-Schönlein, purpura, gout, sarcoidosis, leukemia, and Hodgkin's disease. However, it is important to consider that due to the various symptoms of rheumatic fever, the differential diagnoses are broad. There were no specific red flags identified in the research for a patient with acute rheumatic fever. However, the red flags associated with sore throat, which may be indicative of rheumatic fever, include rigors, shaking, chills, high fever, night sweats, and unilateral neck swelling. All patients that have a suspected diagnosis of rheumatic fever should be admitted to the hospital to confirm diagnosis and assess clinical features and severity. The diagnosis of acute rheumatic fever is made on the basis of identification of major and minor clinical manifestations of the disease as detailed by the Jones criteria. There are a variety of interpretations of the criteria and guidelines that vary in different settings, most notably in areas where acute rheumatic fever is endemic. The latest revision of the Jones criteria was published in 2015 and provides two separate sets of criteria. One for low-risk settings, those with rheumatic fever incidence greater or less than 2% or 2 in 100,000 school-age children, or all age heart disease prevalence greater than 1 in 1,000 population per year. Of the one for moderate to high populations, the diagnosis of a primary episode of acute rheumatic fever can be made in any of the following criteria are met. Evidence of recurrent strep A infection with at least 2 major manifestations or 1 plus 2 minor manifestations present. The 5 manifestations that are considered major manifestations of acute rheumatic fever are carditis, which includes carditis demonstrated only by echocardiogram, arthritis, polyarthritis for low-risk populations, or monoarthritis or polyarthria for moderate to high-risk populations, chorea marginatum, which is that pink rash that's well-defined. It begins as a macula and expands with central clearing. The rash may appear and then disappear before the examiner's eyes, leading to the descriptive term of the patient having smoke rings beneath the skin. And then subcutaneous nodules are another manifestation. 4 manifestations that are considered minor manifestations of acute rheumatic fever are fever, which is greater than 101.3 for low-risk populations, or greater than 100.4 for moderate to high-risk populations. Arthralgia or polyarthria for low-risk populations, and monoarthralgia for moderate to high-risk populations. Elevated inflammatory markers such as ESR and CRP are assessed, and dependent on those factors, if they're high, that's indicative of elevated inflammatory markers, which each are based on low and high risk populations. Also, prolonged PR interval or electrocardiogram after accounting for age variability. A prolonged PR interval that resolves over 2 to 3 weeks may be a useful diagnostic feature in cases when clinical features are not definitive. First degree heart blocks can sometimes lead to a junctional rhythm. Second degree and even complete blocks are less common but can occur. In the resurgence of an acute rheumatic fever in the US, 32% of patients had abnormal arterioventricular conduction. So, diagnostics. There are no definitive diagnostics for acute rheumatic fever. A clinical diagnosis of acute rheumatic fever should be made using the Jones criteria. A 2015 revised version of the Jones criteria endorsed by the American Heart Association now includes the addition of subclinical carditis as a major criteria and stratification of the major and minor criteria based upon epidemiological risk, which is low, moderate, or high-risk populations. The first diagnostic test to consider when suspecting rheumatic fever is erythrocyte sedimentation rate, or ESR, and CRP. These are part of the Jones criteria and assess for elevated inflammatory markers. A white blood cell count should be assessed and may or may not be elevated. White blood cell count is not included in the Jones criteria. Blood cultures are beneficial if a patient is febrile and can be used to exclude bacteremia and should have no growth for patients with acute rheumatic fever. An electrocardiogram to assess the prolonged PR interval and an echocardiogram can assess for morphological changes to the mitral and or aortic valves. A chest x-ray will potentially identify chamber enlargement and congestive cardiac failure if a patient is positive for acute rheumatic fever. A throat culture and rapid antigen group A strep should be conducted to assess for growth of beta hemolytic group A streptococci. Lastly, an anti-streptococcal serology should be conducted to assess for antecedent infection. And then on the next slide, I've just kind of placed the Jones criteria that I got from the Centers for Disease Control and Prevention that gives you a more visual idea of the different major and minor manifestations that are possible. There are multiple different versions of the Jones criteria. The main one to base everything off of is from the American Academy of Cardiology. Now I'm going to talk about a management plan. All patients that have a suspected diagnosis of acute rheumatic fever should be admitted to a hospital to confirm diagnosis and assess clinical features and severity of acute rheumatic fever. There are certain patients with a confirmed diagnosis of acute rheumatic fever that have a mild illness and may be managed as outpatients after an initial period of stabilization. The goals in the management of acute rheumatic fever include confirm the diagnosis of acute rheumatic fever, provide treatment for symptoms, and decrease the acute inflammatory phase, in particular polyarthritis, which can be very painful. Educate the patients and family about acute rheumatic fever, begin secondary prophylaxis, and discuss the importance of secondary prophylaxis, as well as educate the patient as to why this is important. We should offer dental treatment or education regarding the prevention of infective endocarditis, which can occur after acute rheumatic fever infection, and we also want to ensure that the patient follows up. The pharmacological management. The primary recommended treatment option for confirmed diagnosis of acute rheumatic fever is single injection of penicillin G, benzathine, which is given every 21 to 28 days, and most patients should be given or begin on a 28-day regimen, Though patients that develop a breakthrough episode of acute rheumatic fever in spite of good adherence can be changed to a 21-day regimen. Oral agents are used in the case of shortages of penicillin G, benzathine, and patients with proven penicillin allergy can be managed with oral erythromycin. An allergy to penicillin should be verified by history and confirmed with testing by an allergy specialist if necessary prior to choosing an alternative to penicillin. Options for prophylaxis include penicillin V, macrolides, sulfadiazine, with the preferred agent being penicillin V. Salicylates and anti-inflammatory medicines may be started as well to relieve inflammation and decrease fever, as well as the management of cardiac failure. The prevention of acute rheumatic fever. The primary means of preventing acute rheumatic fever is diagnosis and adequate antibiotic treatment of group A strep pharyngitis. Generally, appropriate antibiotic treatment of streptococcal pharyngitis prevents acute rheumatic fever in most cases. However, in a minimum of 1/3, acute rheumatic fever episodes occur in the setting of subclinical streptococcal infection. Acute rheumatic fever is also not preventable in patients that are symptomatic and do not seek medical care. The secondary prevention of rheumatic fever requires antibiotic prophylaxis to decrease the chances of recurrent attacks in individuals with a history of acute rheumatic fever. Individuals that develop subsequent GAS pharyngitis are at high risk for a recurrent attack of acute rheumatic fever. Rheumatic heart disease becomes more severe with each recurrent episode. Therefore, the most effective method to limit the progression of rheumatic fever disease severity is prevention and recurrent GAS pharyngitis. Continuous antibiotic prophylaxis is recommended for patients with a well-documented history of acute rheumatic fever. The first study that I'm going to talk about in the part where we're supposed to review some articles and evidence-based practice, I'm going to talk about, it was a Cochrane review from 2013 that assessed the effects of penicillin as well as penicillin regimens for preventing streptococcal infections and rheumatic fever occurrence or reoccurrence. There were a total of 9 trials that were included in this review. The review was heterogenic, so data could not be combined. 3 trials compared penicillin with a control. 4 trials compared intramuscular with oral penicillin, and all showed that intramuscular penicillin reduced rheumatic fever recurrence and streptococcal throat infections compared to oral penicillin. 1 trial compared 2 weekly with 4 weekly intramuscular penicillin injections. 1 trial showed 3 weekly intramuscular penicillin injections reduced streptococcal throat infections compared to 4 weekly intramuscular penicillin. The review included a total of 3,008 patients. Overall, the review found, like I had stated previously, that intramuscular penicillin appeared to be more effective than oral penicillin in preventing rheumatic fever recurrence and streptococcal throat infections. It also found that 2 weekly or 3 weekly injections appeared to be more effective than 4 weekly injections. However, it must be considered that evidence based on the evidence that we have is based on the poor quality of trials, which can affect the results. The second study that I am going to discuss is a Cochrane review as well from 2013. The review assessed the effects of anti-inflammatory agents in the prevention or reducing further valvular damage in patients with acute rheumatic fever. There were a total of 8 randomized controlled trials that were included in a total of 996 participants. The randomized controlled trials compared anti-inflammatory agents such as aspirin, steroids, immunoglobulins, and ventotoxifylline to placebos or controls, or compared any anti-inflammatory treatment to the other. Participants were both children and adults that had been diagnosed with rheumatic fever based on Jones criteria or modified Jones criteria. The results of the study concluded that the antiquity of most trials restricted statistical analysis and the risk of bias was substantial. More studies should be conducted to assess the effects of corticosteroids as well as other anti-inflammatory medications. The third study I've chosen to discuss is a qualitative study from 2016 that used semi-structured interviews with patients. The goal of the study was to gain a better understanding of the enablers of and barriers to the uptake of secondary prophylaxis. The target population was an Aboriginal and Torres Strait Islanders in Australia with rheumatic fever and or rheumatic heart disease. With rheumatic fever and or rheumatic heart disease. Data was gathered through interviews with patients and parents/caregivers of health professionals to explore the enablers of and barriers to the uptake of secondary prophylaxis in rheumatic fever. A total of 22 interviews were conducted, 11 with patients and 11 with health practitioners. The study found that discrepancies in registration and call systems, as well as pain attributed to injections, were barriers to secondary prophylaxis uptake. Perceptions also varied regarding responsibility for ensuring injection delivery. Enablers of secondary prophylaxis uptake that were identified were positive patient-healthcare provider relationships, supporting patient autonomy, education of patients, caregivers, and healthcare providers, and community-based service delivery. Now I want to discuss some of the patient education pieces for rheumatic fever. Patients with a diagnosis of acute rheumatic fever should be educated on what rheumatic fever is, as well as causes and who is at risk. It's important to discuss with them the symptoms associated with rheumatic fever, especially since it can and potentially will reoccur. The process of diagnosis should be discussed, as well as treatments and prevention. The primary education that should be given to patients is the discussion on prophylaxis. Rheumatic heart disease can reoccur, and it's important to educate patients on how prophylaxis can prevent reoccurrence. Patients should also be educated on the importance of treating sore throats early and recommending antibiotics that are non-penicillin if the patient is taking penicillin prophylaxis. Patients should also be educated on oral health due to the risk of developing infective endocarditis. Patients should receive educational dental care. Patients with carditis should be encouraged to inform their doctor or dentist prior to interventional procedures so that appropriate antibiotic prophylaxis can be given. A laminated card with the relevant details of treatment can be helpful for patients as well as caregivers. Referral and follow-up. The primary referral that's going to occur for a patient with rheumatic fever is to a cardiologist. Any patient that presents with severe carditis, which includes those with significant cardiomegaly, congestive heart failure, or third-degree heart block, require an urgent echocardiogram and assessment by a cardiologist. A patient with acute rheumatic fever that suffered from damage to the heart will need ongoing follow-up with their healthcare provider to check the condition of the heart. This is dependent on the amount of heart damage. There are also maybe activity restrictions for the patient. Otherwise, no specific follow-up recommendations were found, and this may be due to the differences in the severity of the disease. In conclusion, acute rheumatic fever develops after an infection by group A beta hemolytic streptococci that causes diffuse, proliferative, and exudative lesions in connective tissues. More than 2.4 million children have rheumatic heart disease worldwide. However, 94% of these are in developing countries. There are various symptoms and signs that are associated with rheumatic fever, therefore making it difficult to diagnose. Providers need to be able to recognize the major and minor manifestations as identified by the Jones criteria, as well as laboratory and diagnostic tests, which can be used to rule out or implicate other diagnoses. Once a patient has been diagnosed with rheumatic fever, it is pertinent that providers emphasize the importance of prophylaxis to prevent reoccurrence, as well as to treat strep throats early. Now I'm just going to go through my discussion questions. What is the incidence of acute rheumatic fever in the U.S. compared to the global community? How is rheumatic fever diagnosed? Discuss the major manifestations of acute rheumatic fever and the minor manifestations of acute rheumatic fever. Discuss the importance of ESR and CRP level when using the Jones criteria. What are the features of arthritis in patients with acute rheumatic fever? Discuss how valvular heart disease, pericarditis, endocarditis, and heart block are associated with rheumatic fever. Explain in detail a differential diagnosis for rheumatic fever. Why would it be considered a differential diagnosis? And how to rule it out? And what is the role of group A streptococci in the pathogenesis of acute rheumatic fever? And that is my presentation. Thank you, everyone.